propranolol, everything started in the search for the medication to treat angina pectoris. In 1958, most of the scientists are trying to increase the oxygenated blood to the heart in order to compensate the oxygen demand in the heart. However, on the other hand, Dr. James Black tried to block the beta receptors in order to reduce the heart muscle contractility and reduce the oxygen deprivation in the heart. His studies are based on the findings of alpha and beta receptors by Raymond P. Elquist in 1948. After that, dichloroisoproterenol (DCI), which was the lead compound of beta blockers, was developed. However, DCI cannot be used clinically. In 1960s, referring to the pharmacological properties of DCI, Dr. Black continued his work on other beta blocker, which was propranolol. Propranolol was the first clinically useful beta blocker. However, clinical tests showed that propranolol can cause tumors in mice. Therefore, it can only be used for life-threatening situations. Due to the side effects, in 1962, propranolol was synthetically developed by altering some of the chemical structures of propranolol. The synthetically developed propranolol was proven to have higher potency than propranolol and lower cardinomicity in animal model. Later, in 1965, propranolol was launched into the market with Indira as its brand name, and it became the best-selling cardiovascular drug for many years.
The structure-activity relationship of propranolol. The naphthalene ring of propranolol, which is the structure in the orange box, makes propranolol an antagonist of beta receptor. However, it does not make propranolol selective to the subtypes of beta receptor. The methyl branch in the blue box directs propranolol towards the beta receptor. It feeds the hydrophobic pocket of the receptor. The oxygen atom in propranolol is involved in hydrogen bond interaction with the beta receptor. The hydroxyl group next to it is also essential for hydrogen bond interaction. The nitrogen atom, on the other hand, is essential for ionic bond interaction. Substitution at carbon atoms at the positions marked with the pink arrows may increase the metabolic stability of propranolol but may reduce its activity as well.
Now, we proceed to drug-binding interaction. The first one, van der Waals interaction. This interaction forms when the benzene ring of the propranolol interact with the benzene ring of phenylalanine amino acid. Next, the nitrogen ion of the propranolol will form ionic bond with the oxygen ion from the aspartic amino acid, while the hydrogen atom from the alcohol functional group of propranolol will form hydrogen bond with the other oxygen atom of the aspartic amino acid that have lone pair, two lone pair that connected to the carbon by double bond. The last one, the hydrogen atom that connected to the nitrogen in the structure of propranolol will form hydrogen bond with the oxygen that have two lone pair of the asparagine amino acid.
Next, we are going to explain the mechanism of action of propranolol. Propranolol is a non-selective beta blocker, which means it blocks the action of beta-1 and beta-2 adrenoreceptors. Blockade of beta-1 receptors reduces myocardial contractility and secretion of renin, while blockade of beta-2 receptors prevents vasodilation in skeletal muscle. In the case of hypertension, propranolol produces anti-hypertensive effect through several mechanisms. As mentioned before, blockade of beta-1 reduces myocardial contractility and subsequently cardiac output. This will then trigger a reflex peripheral vasoconstriction and reduces peripheral blood flow. As a result, total peripheral resistance decreases and restores the normal blood pressure. However, reduction of cardiac output is not the primary mechanism of propranolol in decreasing blood pressure, but rather inhibition of renin secretion. Blockade of beta-1 receptors on kidney reduces secretion of renin by juxtaglomerular apparatus and subsequently the conversion of angiotensinogen to angiotensin 1, which later will be converted into angiotensin 2, a potent vasoconstrictor hormone. Reduction in angiotensin 2 prevent adrenal gland from being stimulated to release aldosterone, which is a hormone that increases water retention in the collecting duct of nephron in the kidney. Reduction of aldosterone causes less reabsorption of water into peritubular capillary. In short, blockade of beta-1 reduces formation of angiotensin 2 and aldosterone, which will reduce the reabsorption of water and causes a decrease in blood volume. Propranolol is also useful in prophylaxis of migraine. It was found in late 1960s that beta blockers reduce occurrence of migraine in nearly 70% of migraine patients. Migraine occurs due to several causes, one of them being reduction in serotonin level in the brain. This leads to constriction of blood vessel, which will be quickly followed by vasodilation, which causes migraine pain. Propranolol blocks the stimulation of beta-2 receptors, which will prevent vasodilation and relieve the pain. It is proven that propranolol is useful in treating migraine, which occurs 2 or more times per month, and if the headache are severe or complicated by serious neurologic signs.
Now, I am going to talk about the indication of propranolol. The first one is hypertension, in which propranolol lowers the high blood pressure by reducing the cardiac output. Other mechanism known is by the reduction in renin release and also by the central action in inhibiting sympathetic activity. The second one is prophylaxis of migraine, in which the migraine have been thought to be caused by the fluctuation of blood flow in the brain. Thus, propranolol improves the blood flow by blocking the catecholamine in the brain vasculature. It also have been thought to have central action, such as the cross-modulation of serotonin system and also reducing the vigilance. Propranolol also acts as membrane stabilizer. Usually, beta blockers are not prescribed to stop migraine attacks that are already progressing. The third one is angina pectoris, in which this heart pain is caused by the increase in oxygen demand more than the oxygen supply. Therefore, propranolol reduces the oxygen demand by reducing the heart rate and contractility. Usually, along with nitrates, propranolol are prescribed for the treatment of stable angina, usually after physical exercises and strenuous activities. The fourth one is myocardial infarction, in which it has been believed to reduce mortality. It is because propranolol have protective effect on myocardium and inhibit subsequent cardiac remodeling. It also reduces infarct size. Next is arrhythmia, the abnormal rhythm of heart rate, in which propranolol inhibits sympathetic influences on cardiac electrical activity, thus decreasing the sinus rate and prolong AV conduction. It also have been thought to increase the action potential duration and also effective refractory period. It is best used with a pacemaker. Then, glaucoma. By inhibiting the sympathetic activity on the ciliary epithelium, it reduces intraocular pressure and also decreases the secretion of aqueous humor from ciliary body. Next is hyperthyroidism, in which propranolol inhibit the sympathetic activity and block the effect of thyroid hormone. It is useful in thyroid storm, where the blood pressure and heart rate soar to dangerous levels. And the last one is anxiety, where propranolol helps in controlling somatic symptoms.
オイラたちは強いゲームの魔導士だ。
The adverse effects of propranolol are firstly, propranolol is very contraindicated for asthma patients. This is because propranolol is non-selective beta blockers, and once it's blocked beta-2 receptor at circular mass of bronchus, it can cause bronchoconstriction. Secondly, propranolol can cause hypoglycemia due to glycogenolysis decrease. However, propranolol can mask the symptom of hypoglycemia such as nervousness, sweating, and tachycardia. This is known as hypoglycemic unawareness. Lastly, propranolol can cause nightmare as it is very lipophilic drug and can cause blood-brain barrier.
Now, let us discuss the relevance of using propranolol as the first-line drug therapy in hypertension and migraine. Hypertension. There are 5 classes of antihypertensive drugs which are ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, thiazide, and beta blockers. So, all classes of drug may act as the first-line drug therapy except for beta blockers. In single drug therapy, they are all similar in their efficacy to reduce blood pressure. Thiazide diuretics, however, have been associated with the risk of diabetes, so it should be used as a first-line therapy only in older patients where the risk of hypertension outweighs the risk of diabetes. Beta blockers are no longer used as first-line treatment for hypertension unless with compelling reasons. This is due to the presence of more efficient drugs. Propranolol showed less efficacy in lowering systolic and diastolic blood pressure. It also shows more adverse effects. For example, propranolol increases the risk of type 2 diabetes due to the inhibition of beta-2 receptors, which inhibits insulin release. According to the National Heart Foundation of Australia, calcium channel blockers were shown to reduce all-cause mortality and the incidence of stroke when compared to beta blockers. Also, ACE inhibitors were reported to reduce the incidence of myocardial infarction when compared to beta blockers. In contrast with alpha blockers, beta blockers do not cause postural hypotension. Many drugs are chosen over propranolol due to the presence of comorbidities in patients. In comparison to other beta-1 selective antagonists and other drugs, propranolol is not effective in reducing stroke. In fact, propranolol increases the risk of stroke. Only beta-1 selective antagonists are used in patients with chronic heart failure. Since propranolol is a non-selective beta blocker, it is not the drug of choice. However, propranolol is recommended in the treatment of patients with myocardial infarction. Propranolol is used as a drug of choice in certain situations such as patients that have contraindications with other antihypertensive drugs, previous drugs did not lower their blood pressure to the desired target, and patients with evidence of increased sympathetic drive. Migraine. Migraine is usually treated with non-steroidal anti-inflammatory drug, NSAIDs, and other analgesics. Propranolol is only used as the first-line prophylactic agent against migraine alongside other drugs like amitriptyline, divalproex or valproic acid, and topiramate. Among the beta blockers, propranolol and timolol were approved by the FDA for migraine prophylaxis. Generally, propranolol is safe to be used.